proud privilege to introduce Dr. Jatin Shah, who is known nationally. He is the director of the Mumbai Fertility Clinic and IVF Center and has helped establish the first IVF-assisted pregnancies in UP and Kerala state. He's co-authored a book, a textbook, which is the Photographic Atlas of Gynecological and Obstetric Operative Techniques in his cumulative. And he's won many awards and he's pioneered the setting up of IVF centers in many cities such as Cochin, Agra, Madurai, Ennore, and Chennai. With more than 500 national and international presentations, guest lectures, keynote addresses, and ovations. And he's also the founder member of the Aspire. He has published original research papers related to the use of GCSF in repeated IVF failures, association of progesterone elevation on day of HCG, and preterm birth among pregnancies conceived by ART. So over to you, Jatin, who will speak to us on versatility of LH activity for COH in high risk. Jatin, over to you.
Thank you so much, respected Dr. Durusha, Professor Sadhna Desai, Dr. Madhuri Patil, Sonia Malik, Dr. Ricardo, all my distinguished co-speakers, ladies and gentlemen. It's indeed a pleasure to be here today participating in this excellent academic workshop. And I'd like to thank the PCOS Society of India for this opportunity. The lecture I'm going to give today is almost like the song Circle of Life. You know, we now have a circle of gonadotrophins. When I started 30 years ago, we had just HMG urinary by the name of Pergonal available to us, which we used for all IVF patients. Then came in a lot of research that PCO patients have elevated basal LH levels in 60%. It's better to use FSH for these patients. So we had a formulation of urinary FSH. Then they said this has too many impurities, so let's move on to highly purified FSH. Still, we had impurities from urinary contaminants. So then we had the development of the recombinant FSH, which we've been using for more than 20 years now. We now also have long-acting recombinant FSH, and soon probably we'll have an oral FSH. But now, very recently, as Dr. Sadhna Desai pointed out, we have a huge study, the Megaset HR trial from 31 centers in the US, which finally shows that this circle has turned completely around again, and maybe we should be using LH and some HMG for PCO patients and high responders as well. So let's start as to what really has this revolution come up to. Why is high responders so important? We know that high responders in any clinic would constitute almost 20 to 30% of your IVF patients. Of all the reproductive manifestations, I want you to particularly focus on early pregnancy loss. So I'll tell you all the points that you need to focus so that you understand the Megaset trial well. We also know that it's very easy to predict a high responder on the basis of high AMH and high AFC levels. I'm sure all of you are well versed with that, classical patterns of PCO, previous history of more than 15, 20 oocytes and so on. The important point, again, the second point after early miscarriage is that although you get 20, 30, 40, sometimes 70 or 80 oocytes in these patients, what is more important is oocyte quality. And when you actually do an IVF evaluation, you will see that a lot of PCOS patients, especially those with obesity or insulin resistance, have abnormalities of the mitochondrial morphology. We know that a high fat diet and obesity reduces the mitochondrial membrane potential, not only at the GV, but also at the metaphase 2 stage, which in turn gives us poor oocyte and embryo quality in some of these patients. What are the challenges that we face? When we do ovarian stimulation, we had beautiful lectures by Madhuri and Professor Sadhna Desai. But just to recap a bit, one, the propensity for an exaggerated follicular response. So be prepared that you are not going to get 5 to 15, which is the ideal number, but you will get something more than 15 and 90% of these patients. A lot of difficulty in titrating gonadotrophin doses. So your initial selection of the dose has to be perfect. Increased risk of cycle cancellation if you don't have a vitrification backup, if you can't use an agonist trigger, if you somehow by mistake given an agonist protocol, you would end up with a cycle cancellation. Increased incidence of OHSS, tendency to premature progesterone rise. Now this again, remember this point because we are going to read about this again in the Megaset trial. Poor oocyte quality, as I told you earlier, fewer top quality embryos. You get 30 oocytes, but just 5 embryos, which are good. And the increased risk of early pregnancy loss. Now, what do we want to achieve when we do ovarian stimulation for these high responders? You want an effective protocol. We know we want safety. We want a cost-effective protocol. But from our point of view of high responders, the most important points are you don't want OHSS. So you have to be a OHSS-free clinic. You want to minimize premature progesterone rise if you are planning to do fresh embryo transfers. You want better quality, especially top quality oocytes and embryos. You want to increase your cumulative live birth rate. So you want more top quality embryos for freezing, and you want to reduce early pregnancy losses. We know that the approach today, even for normal responders and all patients, is to do and finish off with just one good cycle. So with one cycle, you get enough euploid top quality embryos for freezing so that you have a good cumulative live birth rate for 80 to 90% of your patients. Pre-treatment, we had a lot of interesting questions, but just some important take-home points here. One, if you noticed in Madhuri's lecture, there were two take-home points. That one beautiful study where 10 days of OC pill gives you a very good outcome in PCOS patients. And the second was the ASHRAE guidelines, where 12 to 28 days of OC pill is not recommended. Please, please take home this message that do not use more than 10 days of OC pill pre-treatment, especially in potential high responders. And why? Because most of them are going to need an agonist trigger. For the agonist trigger, you need a good pool of endogenous FSH LH. If you are going to suppress the endogenous LH too much with prolonged OC pills, you will not have a good LH surge. And which is why I get so many phone calls that I got 40 follicles, but with the agonist trigger, somehow it didn't work. I got just 20 oocytes, only 5 M2s. Just look back, you must have used the OC pill for a prolonged period of time. And you can see this beautiful slide here. The more the suppression of LH at the start of stimulation, the higher is the chance of a suboptimal response. You can see almost 40 to 50% cycles will have a suboptimal response if you have given prolonged OC pill pre-treatment in these patients. The other simple way, which I like to do, is a lot of these patients might have elevated progesterone or LH levels on day 2. Antagonist pre-treatment also, as we heard, works beautifully well, especially if you're not doing batch IVF. Just give it on days 2, 3, and 4. Begin stimulation from day 5. And even if she had high progesterone on day 2, you can see the progesterone within 3 days is back to normal, and the outcomes of pregnancy rate are also back to normal with this simple pre-treatment. So just 3 days of antagonist works like magic. Selection of protocol, I think there is no argument or debate here that the way to go for all high responders is the 3 musketeer approach. You have to use an antagonist protocol. You're playing with fire if you're going to use an agonist protocol. Most of the time, you will have to give an agonist trigger if you have more than 15 follicles to ensure you are OHSS free. And in that case, because of the deficient corpora lutea, you will have to do a freeze-all and a frozen embryo transfer. Also, number of eggs, we have had a paradigm shift now. We know initially, as we heard earlier, 5 to 15 was the best number for a fresh embryo transfer. Anything more than 15 and the pregnancy rates dropped. But we now know that what is more important is fresh and frozen cumulative live birth rates. And you can see these go on increasing till 25, 27 oocytes, after which there is a plateau. So your target should be 20 to 25 oocytes in high responders. Dose titrations, a lot of you might start with say 225, 300 and then see, oh, there are 30, 40 follicles. Let me reduce the dose on day 7. This is just not going to work, because if you look at basic physiology, it takes 3 days, even after you stop or reduce the FSH, it takes 3 days for this FSH concentration to fall below the threshold where new recruitment ends. So this is not going to work. Your initial selection of the dose has to be perfect. So please remember that. Another important point, those of you who believe that high progesterone on the day of HCG will impair fresh pregnancy rates, look at this. The more the oocytes that you retrieve, the higher is the percentage of patients who will have an elevated progesterone on the day of HCG. So this is very important point, that a lot of these patients would have a tendency to elevated progesterone on the day of HCG. Why we got sold on the 3 musketeer approach? 5 years ago, we did a short trial. Most of these were antagonist cycles, all patients of PCOS, 127 of them, all took an agonist trigger, vitrification and thaw transfer. Beautiful pregnancy rate in the first frozen embryo transfer as high as 56.6%, reduced incidence of early pregnancy losses at just 12.5, giving a clinical pregnancy rate of almost 50% in the first frozen embryo transfer. And this continues, and as Madam Desai also showed, around 54%. Coincidentally, it's almost the same with freeze-all at our center too. And now we come to the main area, that LH supplementation, should it be given to PCOS patients or not? So the question is, do high responders do better with the addition of LH? We know that hypo responders need LH. We know elderly women need LH. We know poor responders need LH most often from the beginning rather than adding it from day 6 or day 7. But what about high responders? And with what? Which LH do you use? We had a lot of refinement of gonadotrophins. And finally, we have these available to us today. And what we are going to focus today on is Menopur, which is not a routine HMG because it doesn't contain native LH. It contains HCG-driven LH activity. And you're familiar with all the other preparations that are available to us. 95% of the LH bioactivity in Menopur is provided by HCG. And if you compare it to the first generation HMGs, HPHMG has the highest HCG content as compared to any of them. Why am I talking so much about HCG? HCG is 6 to 8 times more potent than LH, and the half-life of HCG is also 6 to 8 times longer than that of LH. So when you give HCG from day 2 of cycle, it tends to accumulate, giving you a higher and higher HCG concentration because the half-life is so long compared to native LH, which is washed out in a couple of hours. So we had these 3 trials which have already existed for a few years now, the EISG, the MERIT for agonist cycles, and MEGASET for antagonist cycles, comparing HPHMG and REC-FSH, and most of them showed that HPHMG, if not superior, is non-inferior to REC-FSH when it comes to normal IVF patients. But we still didn't have any data as to whether it should be used in potential high responders. The MERIT trial was the first one in 2006, comparing Menopur with REC-FSH. And you can see here, Menopur had a higher ongoing pregnancy rate, did not achieve statistical significance, but again, it proved the non-inferiority of Menopur over REC-FSH. This was, of course, for normal patients. We are not talking of high responders. 2012, Devroy gave us the MEGASET trial for, again, normal IVF patients. Again, although most of the outcomes were better with HP-HMG, the trial concluded that there is non-inferiority of HP-HMG as compared to REC-FSH. What about the tendency to premature progesterone rise and endocrine profiles? And we had this study in 2007. You can see with HP-HMG, the progesterone levels are significantly lower than what you get with REC-FSH, which is but expected because REC-FSH gives you higher number of oocytes. As I showed you earlier, the more the number of oocytes, the higher the tendency to a premature progesterone rise. And again, Fadi Sharara showed in 2016 that when you compare HP-HMG to mixed protocols of urinary with HP-HMG, you have a significant reduction in the incidence of premature progesterone rise. So again, we had a point here that somehow HP-HMG gives you a better outcome in terms of progesterone levels. What about embryo quality? So again, we had Z-based study from 2007 where they compared embryos with HP-HMG and they found that HP-HMG had significantly more top quality embryos compared with REC-FSH. Implantation rates therefore were significantly higher with HP-HMG. And they concluded that in patients with only top quality embryos transferred, 48% in the Menopur group achieved live births versus just 32% when REC-FSH was used. So this was one of the initial studies. And again, this is a very important take-home point because I'm going to show you in the megaset how this changes the entire picture. Even Thusen showed in 2012 that not only HP-HMG, but even if you add simple HCG to REC-FSH, the higher the HCG added, the more is the number of top quality embryos per patient. So there was a lot of evidence. And here, of course, you can see because HCG accumulates, the higher the accumulation of HCG. If you see day 6 HCG levels, the higher the HCG level on day 6, the greater is the number of top quality embryos. And this, of course, translates into live birth rates. You can see here, when you compare LH levels on day 6 with the use of native LH, there is no change in the live birth rate because there is no accumulation. But when you use HP-HMG, because of the accumulation of HCG, the higher the HCG level on day 6, the higher is your take-home live birth rate. What about OHSS? You know, we keep hearing that antagonist gives you a decreased OHSS incidence compared to the agonist protocol. Yes, that is if you use the agonist trigger. If you actually see high response, means the number of oocytes, this study, this beautiful study in 2014, compared that. They compared the agonist and the antagonist, and they compared HP-HMG versus REC-FSH. And contrary to belief, they found that the number and the incidence of high response is the same in both, but OHSS seems to be lower in antagonists because we use the agonist trigger. So that is the whole point which needs to be taken into consideration. And what is more important is that when you use HPHMG, the blue bars are the HPHMG, you have a much lower incidence of high response. And at the same time, it showed higher live birth rates per cycle and per transfer with HPHMG as compared to Reg FSH. So this study showed us then that HPHMG and the initial selection of gonadotropin is very important in high responders, because HPHMG is associated with substantially lower high response rate than Reg FSH. And very interesting, they explained that why. A lot of you will ask me that how does HCG or LH give you this better response? And this may be attributed to the different FSH isoform profiles between HPHMG and Reg FSH, and also the LH activity in HPHMG early in the stimulation induces an initial higher level of androgens, which in turn increase the sensitivity of the follicle to FSH, which in turn leads to a decrease in granulosa cell proliferations and also decreased number of follicles recruited. And that is why you get a lower number of follicles and less hyperstimulation when you use HPHMG. And again, the study showed lower incidence of PPR2. So that brings us finally to the Megaset HR trial now. That what are the conclusions from the Megaset HR trial? Now, what is this trial? It is comparing menopur in antagonist cycles with a single embryo transfer in high responders, which is the whole basis of this workshop, versus Reg FSH, conducted over 31 centers in the US and published this year in May 2020. Important to note here that the patients which were selected had normal testosterone. So we are not talking of the very high androgenic PCODs in this patient. And of course, high BMI, high AMH, and all the other criteria as expected. So they had a randomized control between HPMG or Reg FSH with the antagonist, HCG trigger, agonist trigger if more than 30, which I think was a bit too much. They must have had a lot of hyperstimulation, and single blastocyst embryo transfer in a fresh cycle. So in the same cycle, most of the patients, if they were not candidates for moderate to severe OHSS, had single blastocyst transfer. Primary endpoint, of course, was ongoing pregnancy rate per cycle, but very important also, number of oocytes, cumulative pregnancy rates, early pregnancy losses also were considered. And here you can see after the failed fresh cycle, they had 3 frozen cycles usually completed within 6 months from randomization. When they compared the basic demographic data, it was almost similar in both the groups, except as expected, the number of oocytes retrieved significantly lower with HPHMG as compared to Reg FSH. Now, a lot of you would say this is a disadvantage, but it's not, as I'll show you subsequently. E2 levels, again with Reg FSH, much higher increase. In fact, twice as much with Reg FSH when you see E2 levels on day 6. And this is why Reg FSH has a higher tendency for moderate to severe hyperstimulation. When you look at fresh cycle outcomes, ongoing pregnancy rates were higher with HPHMG. Live birth rate per transfer also higher with HPHMG. Significant early pregnancy loss much lower with HPHMG as compared to Reg FSH. Now, this is why when I started the lecture, I told you to focus on the early pregnancy losses. Very, very interesting, the next 5 slides are, and you can see here, initially you get 7 less oocytes when you compare HPHMG and Reg FSH, which then translates into 5 less metaphase 2. So 7 has become 5, the difference starts narrowing, which then translates into 4 less zygotes, which then translates into 3 less blastocysts, but it only translates into 0.9 less top quality blastocysts. So the top quality blastocysts, excellent blastocysts on day 5, is the same despite 7 fewer oocytes with HPHMG. And the advantage of retrieving more oocytes with Reg FSH is therefore lost during this course of embryo development. And this was a very, very important take-home point of the Megaset HR. What about frozen transfers? Those who failed the fresh cycles then went on to do frozen transfers. Live birth rate with FET again higher with HPHMG at 63 versus 50%. Cumulative early pregnancy loss again almost half with HPHMG as compared to Reg FSH. So these are very, very important points that this is taking us through the entire circle back to where we started with HMG 30 years ago. What about cumulative live birth rates? When you put all the fresh and frozen transfers together for a patient over 6 months, what did they find? Cumulative live birth rates were the same in both arms, but cumulative live birth rate in 6 months in the HPHMG group was achieved with 43 less transfers. So fewer transfers were required to achieve that cumulative live birth rate, and more importantly, with fewer embryos. So although PGT was done for all the frozen embryos and most of them should have had a single transfer, because of the initial failures in the reg FSH group, for some reason there was a deviation in some centers and they had a greater number of transfers involving multiple embryos in 39 patients versus just 17 in the HP HMG group. OHSS again significantly lower. You can see 9.7% with HPHMG as against 21% with Reg FSH. And this finally brings us to the Megaset HR conclusion that compared to all the previous trials, once again, HPHMG did fare better. Although I am not giving you a take home message that the live birth rate per cycle is higher, but what they concluded was, and what I feel you should remember, is that the safety profile is excellent. HPHMG is non-inferior to REC-FSH as far as ongoing pregnancy rates are concerned. Cumulative live birth rates were associated with fewer transfer procedures required, lower number of embryos required for transfer, higher ovarian response with the REC-FSH. Getting 7 more eggs did not confer a clinical benefit. In fact, gave you a higher incidence of hyperstimulation because of higher E2 levels. Most importantly, reduced early pregnancy loss rates in both the fresh as well as the frozen cycles. So once again, I would like to thank the PCOS Society of India, especially Dr. Durusha, Dr. Madhuri Patil for inviting me here today. Time was short, otherwise I would have loved to elaborate more on the Megaset HR trial, but this is truly a big revolutionary paper and trial which has been published, and I invite any discussion or question on this. Thank you so much.
Thank you so much, Jatin. I think that was an excellent presentation, and I would like to invite questions from the audience. I think there have been some questions which have already come in, and one of the questions is that it's not related to your talk, but there's one with question from Dr. Sabah asking about enumerate different ways to lower basal LH levels in PCOS prior to stimulation.
Yeah, so one is, as I told you, 10 days of OC pill usually suffices. Anything more than that is not required. Then I think norethistérone, which was discussed earlier by Madhuri, also is a good way of pre-treatment. But I think the best and the simplest is just give 3 days of antagonist on day 2, 3, 4 and start stimulation for day 5. And that takes care of elevated LH, progesterone, estradiol, whatever may be aberrant in that particular case. So I think those are pretty simple to do.
So would you continue using LH, antagonist in all your patients of PCOS, or would you like to do the investigations and then start?
No, normally I don't do any hormone investigations. So I either directly start stimulation. I just go by my scan. If there is good endometrial shedding, both the ovaries are quiet, we just start stimulation because we know she's going for a freeze also. I don't really worry. And since we started doing dual stimulation, a lot of our concepts of this high LH in the follicular phase is changing a bit. In the dual stimulation, we start stimulation in the luteal phase. When you've just done an egg retrieval, obviously progesterone levels are high, LH levels are high, and still we are able to get a better crop of eggs and embryos. So this whole thing, we need to rethink a bit. So I think just day 2, 3, 4 of antagonist usually suffices. Even no pre-medication is fine if they are anovulatory. Now, if she is amenorrhoic and she is not getting spontaneous 28-day cycles, whether you start on day 2, day 5, day 8, day 10, day 12, day 15 without pre-treatment, your outcome is going to be the same. So you don't really need too much of pre-treatment in these patients.
Right. So would you give antagonist to all your PCO patients? 2-3 days of antagonist and then stimulation?
If that is for the question which was asked. So if they are doing and they find that, okay, the progesterone is high or the LH is high, progesterone is unlikely to be high because she's anovulatory. But if you are worried about LH, then just without doing the estimation as a routine, you can give 3 days of antagonist to everyone. That's what Blockil is now recommending for all IVF patients, whether they are normal responders, poor responders, high responders. I showed 1 or 2 slides. Of course, it's a different lecture in itself, just pre-treatment. But it's very interesting that just 3 days of antagonist works for all the categories of patients.
Yes. So then you can
really add on to cost too much.
Right. Madhuri, any questions from your end? Because we don't have any other questions at the moment. There's one question, I'm sorry. In GnRH antagonist cycle, this is Dr. Padmaja, with PCOS, we have a group of women who have very low LH on the day of HCG. And in them, dual trigger with agonist plus injection HCG 2000. The oocytes also which are retrieved are few. So uh, I don't understand this question. We start telling she has more follicles and less. Could you give us a way out?
No, so there may be a lot of differential diagnoses now. Maybe one of the follicles was a cyst and your timing is wrong, and maybe you misjudged it for a follicle. It's actually a cyst which became 18 and you gave the trigger, or there could be a lot of things. So normally we don't check LH on day of HCG. So, and when you're giving a dual trigger, you are supposed to retrieve 95 to 100% of the oocytes and get 90% of them as metaphase 2s. So it's quite a difficult situation. So I don't think if you've been monitoring her from day 2 and you know that it's an absolute uniform cohort of follicles, and if you wait for 18, 19 millimeters to give the trigger, very unlikely that anything like this should happen.
Right. Suppose you would take a patient, I mean, whom we have used the routine, the HMGs which are available in the city today, and you compare it with the HMG which has HCG activity.
That's a very good question, madam. I was expecting that. So we need to do that trial now, because whether it's the HCG which is working or just the LH which is working, we don't know. But I have because of all the studies where, accumulation of HCG is what is giving better top quality embryos and higher pregnancy rates, I have a feeling that they may not be the same. And maybe that is why 30 years ago we shifted from HMG to FSH, because that LH activity was not doing any good for these patients. And of course, that time we didn't have freeze-all, we didn't have antagonist protocols. So it was a different world altogether. But I think it's going to be different. It's not going to be the same. And that is right now the only drawback, that, HPHMG currently is more highly priced than even recombinant FSH. So now this, as a shortcut to whether HMG will work, I don't think it will, but it's a very interesting area for any of us to, do 10 cases and just see if it works.
So after you have read this study, are you going to change your practice?
Oh, I have been using Menopur for the last 5 years. In fact, I wouldn't have accepted this talk, because everybody in India knows that I talk only what I practice and I do. So I have been Menopur since last 5 years for all high responders, normal responders, poor responders. Very happy. Success rates have really gone up. So we were waiting for this trial to add credibility to this experience. So I am very happy, and I was expecting this outcome in the Megaset trial.
Oh, good. Very good. So thank you very much, Jatin. We really appreciated your talk very much.
Thank you, madam. You're all teachers, very senior. It's always a pleasure. Madhuri has also been a teacher. Sadhna madam has been teacher. You're a teacher. So
Thank you.
thank you. Thank you so much.
Thank you for coming in. Thank you. So I'll request Madhuri to introduce our next speaker. And Madhuri, please take it.
Yeah, I would like to invite Dr. Ricardo Azziz, who is going to speak to us on poor response to ovulation induction. How should it be addressed? He has 25 years of leadership experience in higher education, research, and academic health. He is a professor, Department of OB/GYN, University of Alabama, and he's CEO of the American Society for Reproductive Medicine, that is ASRM. He is fellow of the Rockefeller Institute of Government, research fellow in the Department of Health Policy Management and Behavior, University of Albany, State University of New York. He is a clinical professor in the Department of OB/GYN, David Geffen School of Medicine, UCLA. He is a past director of SUNY Hispanic Leadership Institute. He is also the past chief officer of the Academic Health and Hospital Affairs, State University of New York Systemic Administration. He is also the founding CEO and chair of the Roosevelt Warm Spring Rehabilitation and Specialty Hospitals. I now request Dr. Ricardo to take over.
Good morning, or good afternoon or evening for you all. So it's a real pleasure to be here, Dr. Patil and Dr. Shah. Thank you very much for inviting me. And thank you very much for the other speakers, Dr. Patil and Dr. Sai and Dr. Shah. I found to tell you that I'm wondering what I can contribute to this discussion. As most of you know, I do mostly epidemiologic and phenotypic work in PCOS. One of the things that Dr. Patil really glossed over, because frankly it's a little bit long, is I'm also the founder of the Androgen Excess and PCOS Society, which of course we've very well. So I've been asked to actually speak about the poor response to ovulation induction. How should it be addressed? And there's lots of obviously techniques and approaches. You've just heard from Dr. Shah, an excellent lecture. I was afraid I was going to speak too fast, but Dr. Shah put me to shame. So he provided a tremendous amount of information. But there's lots of approaches to doing this. And again, the real question becomes, what is a poor response? So what I'm going to do, and I'm going to take the tact, is to really provide an overview of what the current guidelines are. And then we'll talk a little bit about how this impacts. The first thing I think it's important, because it'll become important as we begin to discuss the response to ovulation induction, is really what the phenotypes of PCOS is. And I think it's very important to understand that while we've had long discussions about diagnosis, NIH 1990, Rotterdam 2003, and androgen excess PCOS Society 2006, the reality is that these three different definitions speak to different phenotypes. So the first phenotype of NIH 1990, which is what we would still call classic PCOS, really refers to individuals who have phenotypes A and B, and that is with hyperandrogenism, ovulatory dysfunction, and they may or may not have polycystic ovaries on ultrasound. And you have to remember that the definition of polycystic ovaries is changing dramatically as we speak about it today. Certainly it is much higher. The cutoff number is much higher. So we'll continue to do that. That's really A and B. Then we have this phenotype C, which is called for both in Rotterdam and Androgen Excess and PCOS Society. This phenotype C is what we call ovulatory PCOS. They're hyperandrogenic and they're polycystic ovaries on ultrasound, but again, they do ovulate regularly. And finally, Rotterdam called for this last phenotype, phenotype D, which really is the non-hyperandrogenic phenotype. Patients have polycystic ovaries, have ovulatory dysfunction, but do not have it. And the reason that these are important is that, as we will see in a minute, these will impact on the diagnosis as well as the prediction of success when you're looking at ovulation induction. It's important for the listeners to remember that actually all of these phenotypes and all of these diagnoses actually require the exclusion of related or mimicking disorders. So at a minimum, they should have an evaluation clinically for things like tumors, et cetera, in other words, based on a clinical history, and they should obtain a 17-hydroxyprogesterone to exclude non-classic adrenal hyperplasia, TSH, and prolactin for other causes of ovulatory dysfunction. It's also important to realize that there are really phenotypes. And so when we speak about phenotypes today, it's really not, it's poor practice, if you would, to diagnose patients with PCOS without actually telling them what the phenotype is, right? And so generally A and B is sort of similar. C, of course, is, as I said, ovulatory PCOS, and D is non-hyperandrogenic PCOS. Now, I think it's also important to recognize that ovulation in PCOS or anovulation PCOS is really not a sine qua non. When those of us who do large epidemiologic studies in populations, and this is one study we did many, many years ago comparing placebo to triglyceridone, you recognize that actually patients with PCOS do ovulate. They just ovulate at a lower rate. In this particular case, when you look at patients with placebo, you will notice that patients with placebo ovulate about 0.3% of the time of what you would expect a normal person to ovulate, about a third of the time. So very often we have these discussions about how did PCOS really last throughout the ages, considering that it actually produces infertility. The truth is it produces subfertility, which tells you that certainly in areas of early intercourse, frequent intercourse, and no contraception, they certainly could be just as pregnant. As we move forward today, I'm going to speak about two principal things. We're going to talk a little bit about the PCOS International Guidelines. These were guidelines that were really driven by the Australian National Health and Medical Research Council, and we're supported with a partnership with a number of different societies, including ESHRE and ASRM. And it's a large coordinated process. I was part of these and continue to be part of these international guidelines. These change, these modify, these move forward. And I'm also going to be emphasizing the use of meta-analyses and systematic reviews. But I will say to you that you have to be careful about this. Because as you use systematic reviews and meta-analyses, what often happens is that these simply magnify existing biases, right? So if it's garbage in, it's going to be garbage out. If you have a lot of flawed studies, the meta-analysis is only going to magnify the flaws. So I'm just telling you that in general, we're going to use these kind of data, but you have to recognize that there are flaws to the system. Initially, if you look at the guidelines and other such issues, lifestyle intervention is always touted for fertility for women as the first line treatment, as being the one that provides the best improvement in quality of life and also an improvement in fertility. But I will simply tell you that randomized controlled trials and systematic reviews of these trials really shows that evidence is very limited relating to the effect of lifestyle intervention for fertility in women with PCOS. I'm not going to show you that data today, except to simply say that in general, when patients come to you for infertility or subfertility, it is best to say you do need to improve your lifestyle. You need to lose weight, as we'll see in a minute, but it is also important to recognize that that will be unlikely to have a significant impact on their fertility in the long run. Of course, many of you recognize the PPCOS trial, the PPCOS-1 trial, which compared clomiphene and metformin to clomiphene to metformin, and showed really that clomiphene was far superior to metformin alone. And I think that's something that most of us who at least have been practicing in the field of gynecology recognize, because frankly, this is driven primarily by non-fertility specialists and by medical endocrinologists who felt that perhaps metformin could improve really the metabolic outcome of these patients and provide some fertility. Now, it is true that it is certainly better improvement in their fertility than zero, than nothing, but in general, it certainly is much less effective than clomiphene, and most of you know this. As you know, then we went into a second trial, PPCOS-2 trial. This one compared letrozole and clomiphene, and again, it showed surprisingly, and I think many of us were surprised about this, that letrozole was significantly better than clomiphene for live birth rates, and so this was something that surprised us. So the current guidelines, international guidelines, of course, call for letrozole being the first line for pharmacologic treatment of ovulation induction. And when letrozole is not available, or its use not permitted, or cost is prohibitive, ovulation induction should be used with clomiphene aware. There appears to be that the risk of multiple births is somewhat less with letrozole compared to clomiphene. Another reason that, in fact, we prefer letrozole. And then we talk about, obviously, clomiphene alone being used in PCOS and metformin alone being used, but really only in women who just are not either eligible for ovulation induction, are not really that interested in fertility, or so on. Now, the real issue becomes when we talk about non-responders, which of course I've been asked to speak about, is what is a predictor of non-response? What really happens with non-response at this particular point, right? And so this is one of many, many studies. There are some beautiful studies throughout the literature, and this is going back almost 40, 50 years. But what are the principal predictors of non-response to clomiphene? And it's actually very similar, by the way, to letrozole. So in many ways, you find, and this is one study that came out of the PPCOS-1 trial, you notice that body mass index, the age of the patient, the hirsutism score, in other words, the assessment of the degree of hyperandrogenism, and the duration of attempting pregnancy are all sufficient to really predict live birth rate in patients undergoing clomiphene ovulation induction, and very much the same for letrozole ovulation induction. So in fact, this is important to note. So again, this is something that you're going to find pretty persistently in almost all the studies in different ways, if you would. Body mass, age, degree of hyperandrogenism or hyperandrogenemia, and the duration of attempted conception are all sufficient to predict live birth rates. And so this is really where you have issues again of where what happens, right, when you don't conceive, and what I call non-responders, meaning people that ovulate and don't get pregnant, or people who don't ovulate at all on on first line therapy, clomiphene or letrozole. What happens and why does that happen? So because again, body mass index is such a massive massive determinant of failure to conceive with clomiphene or letrozole. A study was done, and again, this is one of some studies, but this is a particularly good study on a randomized controlled trial of preconception interventions in infertile women with PCOS. Now, the colleagues assigned 149 women to 3 different lifestyle modifications in a prospective study, 50 to lifestyle modification, 50 to birth control pills, and 50 to a combined lifestyle and birth control pills. And really what after this preconception intervention, the women underwent 4 clomiphene cycles. Now, they did lose weight. Women in this study did lose significant weight, but both lifestyle and combination, and they really did not lose very much weight compared to nothing at all and to birth control pills. Now, what was found is that the prevalence of metabolic syndrome was somewhat higher with oral contraceptives during duration of the study, but there was no change in the prevalence of metabolic syndrome with lifestyle or combination therapy. But more importantly is the really probability of live birth rate, which you'll see here in these graphs. As you can see, the probability of live birth rate was much higher for lifestyle and combination therapy versus oral contraceptive preconception intervention. And you've heard from the other speakers about, again, the duration of oral contraceptives and how much you should give them before the duration, not to give them too long, et cetera. But the reality is that for women who are obese with PCOS, that weight loss is dramatically important. But again, I will caution you that these studies are coming from the United States. And in the United States, we do have a very severe obesity crisis. And so in many ways, many of these patients are very large. Now, we do know that China, India, and so on are also having their own obesity crisis. So we have to understand that. But again, the degrees of obesity may be different. But nevertheless, what this points out is that preconception intervention, particularly around lifestyle and weight loss, is critical for these women. Now, when we now talk about, basically non-responders, or what I would call failure to conceive to first-line infertility treatments, you then have what we call the clomiphene-resistant patient, which basically simply means they either didn't ovulate or ovulated, didn't get pregnant on clomiphene or letrozole, and no really other infertility factors, because we're cleaning this. And this is, again, recommendations from the international guidelines. You can use metformin and clomiphene. There is a little bit for patients who cannot afford to move to other therapies. There is a small evidence, as I showed before, and not just in the PPCOS1 trial, but in other trials, that perhaps metformin plus clomiphene is better than just clomiphene alone, and perhaps better than letrozole, although those studies have not been clear. Or you can move to gonadotrophins, which obviously would be the preferred line of therapy at this particular time. The addition of metformin pretreatment of gonadotrophins does appear to improve the response of gonadotrophins in these clomiphene-resistant women, so that's something that should be considered. And really, gonadotrophins can be effective both in PCOS and clomiphene failure, but again, we're still not comparing it and don't really have a clear idea around letrozole. Finally, the usefulness of letrozole in a clomiphene-resistant patient also has not been studied, so there's still some work to be done. And the reason that this work is important, because many of us, unfortunately, are all involved in ART and IVF and all these kind of things, but the reality is that the vast majority of patients generally either cannot afford to have ART or IVF and other cycles, or simply are treated by generalists and others who do not have that expertise. So we often sort of diminish the value of these early treatments for PCOS without recognizing that a large number of patients may well benefit from these as well here. So the And if we move on to the international guidelines, gonadotropin-induced ovulation should only be triggered when there's fewer than 3 or more mature follicles. You've heard an excellent lecture by Dr. Shah on the treatment of high responders and how that may be addressed. I'm not going to get back into that, but really in our case, again, on an international basis, recommending this for all practitioners throughout the globe, we really do recommend cancellation with more than 2 mature follicles using gonadotropins. Now, we are not talking about IVF here. This is just gonadotropin ovulation induction without the backup of an IVF laboratory. In a minute, we'll talk about IVF, and of course, that is how you begin to treat these non-responders. When gonadotropins are prescribed, we need to really consider a number of things: cost, availability, the expertise available. It does require, in fact, in my opinion, almost as high an expertise to manage gonadotropins as it does to manage an IRT and IVF cycle. You really do need a number of protections, and there is significant risk and implications for the multiple births. Now, if you look at a series of comparisons between laparoscopic ovarian drilling, LOD, or laparoscopic ovarian surgery, however you may do that, versus medical ovulation in regards to live births, this is a very powerful statement. First, that laparoscopic ovarian drilling versus just clomiphene or clomiphene plus metformin really was better. It was better. Laparoscopic ovarian drilling seems to be better for those patients. Not so much better really versus clomiphene and tamoxifen, but we don't really generally use that. It doesn't seem to be much better, but certainly not much worse than gonadotropins, and doesn't seem to be much better nor much worse than letrozole and other such things. So overall, laparoscopic ovarian drilling is a viable usage in these patients who fail, if you would, to standard ovulation induction. And at that point, you can use laparoscopic ovarian surgery in clomiphene-resistant patients with PCOS, really with no difference compared to 3 to 6 cycles of gonadotropins, and with a lower risk of multiple births. And that's one of the things that is clear, that laparoscopic ovarian drilling related pregnancies there's a lower risk of multiple births and ovarian hyperstimulation. So it is possible to offer laparoscopic ovarian drilling as a first-line treatment for patients who are clomiphene resistant who fail standard ovulation induction in lieu even of gonadotropins. The biggest problem I think that I tend to, and I have with laparoscopic ovarian drilling, is that there are some real risks around damage to the ovary, including premature ovarian failure, adhesions around the adnexa, and so on. Plus, it is surgery, which obviously has its own complications. So you have to balance these risks versus the expertise available. Again, a lot of the choice on treatments for patients who are resistant, if you would, or non-responders, as you would with PCOS, really depends on the local and the available expertise. Laparoscopic ovarian drilling is often taken up by individuals who don't have a lot of training, and unfortunately, they tend to think that it is less risky than, say, gonadotropins or ART. And in fact, that is a misnomer, because any damage that they make to the ovaries will be permanent and will be persistent. Now, again, we are talking about non-responders. So what really happens? How do we predict whether there's a failure or success of gonadotropin ovulation induction? Now, a lot of those studies have been done, some in PCOS, but they generally are not very large studies, 30, 40 patients, these kind of things. But this is one study from the Netherlands looking at 154 women with normogonadotropic and ovulatory infertility. Now, it's important to note that these women, had a clomiphene ovulation induction that was unsuccessful. They were non-responders. But it's also important to note that the vast majority of normogonadotropic and ovulatory infertility women are PCOS, right? So this is why we include it here. They were treated with daily FSH, of which 44% achieved an ongoing pregnancy. Now, what were the predictors of non-response? What were the predictors of non-success? Well, interestingly, in this study, again, it is women's age that predicted pregnancy, much as we saw with clomiphene. Total testosterone, again, a measure of hyperandrogenism that we saw, and IGF-1. So IGF-1 as a measure of degree of insulin resistance. And that's what we begin to see in these studies. We begin to see that the degree of insulin resistance, often seen with body mass index, or worsen the degree of hyperandrogenism in a woman's age, again, tend to predict pregnancy. So it becomes a consistent predictor in these women, which is why they need to be treated in advance. So what happens when you have non-responders to gonadotropins, meaning no success to 3 or 4 cycles of gonadotropin, so the patients actually are very prone to over hyperstimulation, multiple births, et cetera, that you don't want to run that risk. Of course, you then move to IVF, and it should be offered, and again, this is from a consensus statement, offered to PCOS in the absence of an absolute indication. In other words, there was a question earlier from the audience as to whether PCOS is an indication for IVF itself. The answer is no, not generally. There are obviously other lines of therapy for ovulation induction and PCOS. But again, in patients who have had non-response, IVF is an option for PCOS, and PCOS is an indication in those settings for IVF. Now, of course, you've heard much about the GnRH antagonist protocol. We're not going to obviously discuss that. That is the recommended protocol and associated with a much lower risk of OHSS and PCOS. In most of the reviews that we're seeing, there was no really difference between HMG and recombinant FSH, as Dr. Shah has shown very nicely in his slides. There is no basically a difference between HMG and recombinant FSH. Again, the most recent trial mentioned was not included in these consensus, but again, there is not really a huge amount of difference in either one, and I think availability of whether the medications and comfort of the clinician is important. The adjunct pretreatment with metformin may reduce OHSS just much as it did with gonadotropins, and it may enhance clinical pregnancy rates. So the adjunct pretreatment with metformin may be something to be considered as well. I think that the risks are relatively small and the benefits may be there. And of course, elective frozen embryo transfer should be considered in PCOS with evidence of lower risk of HSS in the face of similar clinical pregnancies. I think this is becoming standard practice, of course, and that's why we talk about cumulative live birth rates rather than just a single transfer live birth rate. Now, to further reduce the risk of HSS, there is some evidence that IVM, in vitro maturation of oocytes, can be offered, but I will tell you that the data is still unclear. So this is still considered experimental in many settings. Now, in many ways, recombinant LH should not be routinely used in combination with FSH in women with PCOS. That may change according to new data, but right now, those are the recommendations internationally. HCG should be used at the lowest possible doses needed to trigger final oocyte maturation in women with PCOS. And again, you can also use agonist trigger as well. Triggering the final oocyte maturation with a GnRH agonist and freezing, all suitable embryos should be considered in women with PCOS. But again, it depends on the resources of the laboratory, and it depends on the resources of the patient. So again, that is an optimum treatment, right? To trigger, to use a GnRH antagonist protocol to then trigger the ovulation with GnRH agonist, to then obtain as many oocytes as possible, to then freeze as many embryos as possible, and to have an increased cumulative pregnancy rate. That is really the ultimate for many patients, but it is not accessible to many patients. And I think it's important to recognize that as we talk about this. A couple of things, last comments. It's obviously important to understand that serum AMH is a pretty good predictor of ovarian hyperstimulation and better than actually age or BMI. So we tend to use AMH to predict that. But again, between AMH and the follicular picture, obviously you can obtain a pretty good prediction of who's at risk for OHSS. And then secondly, if you look at what the data on IVM is, this is again from the review, and it's a couple of years older now. 2 studies, of course, and it does seem to favor IVM in general versus IVF straightforward for patients with PCOS. But I will tell you that the number of studies that you can see is relatively small. The number of subjects in these studies are small, and of course, this will need to continue to be expanded. So one last comment, and I think we started our discussion with phenotypes, right? I told you that the phenotype of PCOS was very important. I think you've recognized now that certainly hyperandrogenism as a phenotype is much more important than just the diagnosis of PCOS. So patients who are phenotypes A and B will be much more prone to actually have failure, if you would, during ovulation induction, whether it's clomiphene, letrozole, or gonadotrophins, and compared to phenotype D. But phenotype matters. Well, what about IVF? Well, this is a study, a retrospective analysis of 567 patients by Mike DeVos and others, looking at the cumulative live birth rates after IVF in patients with both PCOS or PCOM. And what they found is that, in fact, phenotype mattered, right? So the live birth rate, or the cumulative live birth rate, really were significantly lower for phenotypes A and C. A being, of course, the full phenotype class of PCOS, and C, those are hyperandrogenic patients who really appear to be ovulating normally but are not conceiving, compared to phenotype D, the non-hyperandrogenic PCOS phenotype. And again, compared to controls with PCOM. So PCOM alone, right, the presence of polycystic ovarian morphology in controls was not enough to actually be a determinant of the same phenotype as phenotypes A and C. So really, at the end of the day, PCOS phenotype really was an independent predictor of cumulative live birth rate. And it is the hyperandrogenism of the PCOS phenotypes that actually tends to be much more powerful as a determinant of success in IVF than is just simply the presence of polycystic ovaries, and certainly just the presence or the diagnosis of PCOS. So this is why it's very critical as we begin to examine and treat patients with PCOS undergoing ovulation induction, that we understand what phenotypes we're talking about, because the phenotypes will behave very differently. The success rates will be very different, and the predictability and the need for next steps will also be very different. So with that presentation, I apologize for the speed of the presentation, but I really thank again the Society for allowing me to speak at this early morning for me and this late evening for you. Thank you.
Thank you very much, Ricardo, for that excellent talk. And there are a few questions for you. Sushma Bakshi is asking whether a dual trigger as a routine in normal responders. What is your opinion?
I'm sorry, could you repeat that question?
Dual trigger as a routine. What is your opinion?
Yeah, I don't generally use dual trigger as a routine treatment. No.
When is laparoscopic ovarian drilling indicated in PCOS patients?
So I tend to be, even though I am a former surgeon, and I say a reformed surgeon, I did much, many of you may know that I was president of the Society of Reproductive Surgeons some years ago, et cetera. I have great respect for surgery, but I also understand its limitations. So one of the things that I ask people to do when they consider laparoscopic ovarian drilling is to determine their own personal expertise and their ability to be trained. Two, I actually look at other options. So if I have medical options that the patient can afford and can undergo, then I will proceed to medical options. But there are patients who cannot proceed, certainly in this country and in your country as well, that cannot afford to proceed to IVF, who are high risk for gonadotrophins and ovarian hyperstimulation and so on. And in those patients who have failed clomiphene, metformin, letrozole, whatever other oral medications, I will proceed to laparoscopic ovarian drilling. But again, it's only a very select and small population of patients.
Does it depend on the AMH levels?
Not necessarily. I don't really use AMH levels to predict who will be. And there are studies who obviously look and claim that AMH tend to predict success and so on. But I will tell you that, for those of us who do research in this area, if you have enough parameters, I do a study of 27 patients and I study 72 different variables, I will find associations with, 5 of them, right? And so this is not the way we do research. You have to actually have a better understanding of how that's done. So the answer is I don't use AMH levels to predict who may or may not be amenable to laparoscopic ovarian drilling. I certainly get reassured if they have higher AMH levels that at least I won't be killing out too many follicles. But that's one cycle, one time, right? I mean, it changes. So so I don't necessarily use it just as a judge.
In which patients do you prefer using injectable LH?
You know, in patients, so I don't use, and again, the trial, I'm trying to remember what the trial is, Metaphase HR, but obviously it's not. But the Megaset HR, thank you. Sorry, I just for a second blanked out there. You know, may change my mindset, but I actually do not, and I do not actually add LH to patients with PCOS. I will tell you though that that I think it's important to remember that LH is higher in patients who are thinner with PCOS, right? So we have to understand that we don't understand very well really the interaction between BMI, insulin resistance, obesity-related inflammation, and pituitary production of LH, right? Because, you know, why is it that patients who are thin tend to have higher LH? That's right. That's why many years ago they tend to be reported more often, right? Because most patients with PCOS were thinner. Now with the obesity epidemic, PCOS patients have gotten fatter as well. As you know, we presented a number of studies in that regard. So now their LHs tend to be lower. What does that mean? Does that mean that the actual physiology has changed, or does that simply mean that we're now looking at a marker that is not as predictable as you would? So I don't generally use LH yet, and I may change my mind, and we'll go from there. But right now, it's not something I use routinely.
Is there a role of using dexamethasone as an adjuvant drug during stimulation for 10 days in women who are hypoandrogenic in PCOS?
Right. So this is a very interesting question because it's a dual question. It's a tricky question, whoever answered that, because they threw in the hypoandrogenic PCOS on one side and dexamethasone on the other side. So let me just bring back a few things. I'm going to forget the hypoandrogenic PCOS for a minute, and I'm going to talk about it in a minute. So dexamethasone, we actually studied, and I spent about probably, you know, something like $15 million of the NIH in about 20 years of my career studying the adrenal component of PCOS. And many of you who have followed my career over time can remember that. What we found out and what we ended up really deciding after many, many years is that actually the adrenal contributed relatively modestly to PCOS. It really was not an important organ. It did provide all sorts of things and cool papers and all that kind of stuff, but at the end of the day, it wasn't that important. We also did trials looking at dexamethasone and PCOS, and we found that it really wasn't as predictable an ovulatory drug for PCOS. And so in general, we do not recommend dexamethasone for ovulation induction in patients with PCOS at all. It worsens dramatically their metabolic disorder quickly, like overnight. It doesn't really provide much use, even in patients who have high DHEAS levels and high DHEA levels. So I do not, and absolutely do not recommend dexamethasone. That's why the international guidelines actually don't have that at all, right? Now, you know, we could talk about non-classic adrenal hypoplasia. I'll be happy to come back to the society and talk about that disorder some other day, but that's a different disorder. Now let's come back to the issue of hypoandrogenic PCOS. And I think this is really where we must do some serious studies and do some serious phenotypes. You know, one of the things that I'm a great critic of studies in PCOS is that many people do not spend enough time phenotyping their patients. They should all lump them together, right? It's the lumpers. And I can tell you that what I've shown you is you have to separate them. You have to separate them certainly into phenotypes and perhaps into thin and fat because they tend to react very differently. I don't believe that there is much of a population of hypoandrogenic PCOS. Remember that phenotype D is polycystic looking ovaries plus anovulation, right? Or illegal ovulation. Are those really polycystic ovary syndrome patients, or are those patients who have sort of a primary hypothalamic pituitary ovarian dysfunction that actually makes it look like PCOS, but it isn't PCOS, right? And so, you know, I've been one of those proponents to say that hyperandrogenism tends to be part and parcel of most patients with PCOS. But again, it may not be measurable and it may not be possible, right? So, you know, one of the things that we have to understand about androgens in women is that they are the range is very wide. So you could triple your androgen levels from what you are and still be within the quote normal range, right? So in general, we find this because, for example, if you study menopausal women and you study the women who have low androgens to begin with, middle androgen to begin with, and high androgen to begin with, over time, over decades, the androgen levels remain relatively the same. They'll go down, but they'll stay, you know, the high people will stay high, the middle people stay middle, and the other ones will stay low. So my point is that I'm not a big believer in hypoandrogenic PCOS. I think that we often confuse phenotype D, and that's why I tend to be most suspicious, if you would, of phenotype D.
In a patient who has thin endometrium with letrozole, can we start tamoxifen for the next cycle? If so, what is the dose?
So I'm sorry, can you repeat that about the endometrium?
This is a question from Vidya Priya. So she's asking that despite letrozole, the patient has thin endometrium, because we know that in CC cycles, we do have thin endometrium. So is tamoxifen an alternative, and what dose would you advise?
So I should tell you that I do not check the endometrium. If I understood the question, somebody's checking the endometrium and finding it to be not mature enough, right? Luteal phase defect, whatever you'd like to call it. We do not check the endometrium in those patients at all. I mean, unless you're doing it by ultrasound, and if you're then seeing that the endometrium does not actually develop, if you have basically a thin endometrium, then we'd go to gonadotropin. So I have no experience really with adding tamoxifen. As you saw in some of the studies that I presented, there was some studies looking at clomiphene plus tamoxifen in these studies, but I don't personally have an experience in using it. And I would probably, if I have failed endometrial development in patients with clomiphene or letrozole, I would move on to gonadotropins.
In case there's no response in a cycle where you are giving a oral ovulation, either CC or letrozole, along with gonadotrophins, what is the criteria to stop the gonadotrophins in an IUI cycle?
So to stop the gonadotropins and plus IUI cycle, I'm sorry.
No. When do you stop a gonadotrophin in an IUI cycle? If there's
Move
no
to IVF.
response, if there's no response to gonadotrophin.
Okay, got it. Sorry. So the assessment. So I generally will use up to. And again, we're using this less and less and less because, unfortunately, patients who are coming to us, or fortunately, depending, are, you know, we ASRM, as you know, and other societies are working really hard to improve access to IVF and ART in the United States. So increasingly, a number of women will, throughout their employment and their insurance, at least the way it works in the United States, will have access to IVF. So I would just tell you that the experience with the gonadotropins is actually reducing in our country, and the experience with IVF is increasing. But having said that, I do not give more than 4 cycles of gonadotropins. If patients, if they have 1 cycle, they tend to overstimulate. As I said, they tend to have more than 3 mature follicles. And personally, I stop their cycle after 2 mature follicles, and I cannot control their ovarian hyperstimulation by adding either metformin. So often what I'll do is I'll use gonadotropins. Did not respond well with some degrees of ovarian hyperstimulation, I will then use an ultra low dose in the next cycle with metformin. If that doesn't work, then I may try 1 more cycle. So I will not try more than 4 cycles of gonadotropins. And certainly, if I have great difficulty managing the over hyperstimulation, the risk of that patient early on, then I just move on to IVF.
No, what they were asking is, in a particular cycle, the patient, you're giving gonadotrophins, but you do not get a response. So there's no pharmacogenesis. So for how many days would you continue gonadotrophins before you cancel the cycle?
Well, I to be fair, I've continued gonadotropins for 15 days, 17 days. So sometimes, but the data really, as some of the other speakers have shown, the data shows that once you start really going in a very prolonged gonadotropin cycle, then it's not very successful. But I will tell you that if I start ultra low dose, gonadotropins, then I will continue this for a much longer period of time, particularly if the patient's anovulatory. So I'm not really that concerned about how long I give the gonadotropins, as long as I see a response. As I said, I'll start out with standard dose, and then if they over-respond, I'll go down to a lower dose, and then that may take 10, 15 days for us to see a response.
There's another question by Dr. Sabah Rasul. She's asking, many women with PCOS in an FET cycle do not develop a good endometrium despite different protocols used. But in the fresh cycle, they have the endometrium growing very well. So why is it that? Why is it so?
So if I understood the question, in frozen cycles, they found that the endometrium was not developing well, but in fresh cycle, it's hard for me to answer that. I mean, that generally refers really to the protocol that they are using to prepare the endometrium for the frozen embryo transfer. So what it's telling me is that the endometrium does respond well, does respond to endogenous estrogens. That did really well. And they have to really look at their protocol for stimulating the endometrium, for preparing the endometrium for frozen embryo transfer. Clearly, whatever they're doing isn't working very well. As you know, patients metabolize different estrogens differently. There may be a need to change routes, there may be to change preparations or even doses.
Thank you very much, Ricardo, for that excellent presentation, as well as for all the answers you gave to our viewers.